Welcome, everyone. We'll wait just a few seconds here and let everyone join, and then we'll begin. Okay, looks like we can start. Welcome to the Healthcare Lounge. I'm Kendall of Next Gen Benefits, and today I'm going to go ahead and just turn it over to Mr. Nelson Griswold.
Thanks, Kendall. Great to have you with us today in the Healthcare Lounge. Our guest today is running late and might not be able to make it, so I'm going to carry the ball for the duration. And if John Quinn of Wellnecity is able to join us, he will. I'm going to talk about the topic of the day, which is the complexity of unbundled health plans and how we deal with that, and how we can manage that complexity in a way that not only makes the plan more efficient, but gives us more control over the plan, more data, and more control over the various components of the plan. So when you deconstruct a BUCA health plan or any health plan, but let's say the BUCA black box, which is very complex, it's very complicated. No one could possibly understand or certainly replicate what United Healthcare or Blue Cross or Cigna or Aetna has created in their fully insured big black box. Except that when you open that black box, along with all of the employer's cash that seems to have gotten caught in the box and doesn't quite make it out into paying claims, you also find a handful of components, main components in a health plan. Those components are TPA, third-party administrator, the administration arm of the plan, a PBM to manage the drug program, the pharmacy program, medical management, stop loss. Dirty little secret, every carrier on every fully insured plan has stop loss on each employer's plan. Now, that stop loss is usually purchased from a stop loss carrier the BUCA owns. So the money that changes hands really is going from the right pocket into the left pocket of the BUCA. And of course, if there's no need for the stop loss, then the money stays nicely in the stop loss carrier to help their loss ratio. If they do have to pay out, it helps the loss ratio of the carrier of the BUCA. But there is a stop loss component in even fully insured plans. Then you have some sort of claims repricing mechanism. In the case of the carrier, it'll be a network, which is a discount off of an arbitrary retail price that, of course, no one ever pays. And then finally, you've got the management of the plan. I don't mean the administration, but the management of the overall plan, the marketing, customer service, those sorts of aspects, a lot of which is handled by the broker in terms of marketing it out, selling it, et cetera. So when you deconstruct that very complex black box, you discover it's not very complex. In fact, you demystify that BUCA black box to the point where an employer can believe that you, as a smaller independent employee benefits firm, could actually possibly recreate that model on a smaller basis for an employer by building a plan using those same components, just next gen versions of those components, well, to affect a next gen plan. So the third party administrator should, in its essence, confirm an employee's eligibility, send out the insurance cards, accept the claims, adjudicate the claims, and pay the claims. That is primarily what a TPA should do. It's what it was set up to do. Remember, in a self-funded plan, the employer is the insurance company. So the employer is responsible for accepting, confirming eligibility of the employee. Did the employee sign up for the plan? Are they paying their premiums every month? But also accepting the claims and adjudicating and paying those claims. That's the job that the employer in a self-funded arrangement doesn't want to do. And look who shows up. Here he is, John Quinn. So everybody, I'm going to finish this up and then I'm going to bring John in. But John, I'm just explaining sort of the complexity of the self-funded unbundled plan. And where we had gotten to, I deconstructed the Buka black box and so demystified it. It's not very complex at all, but you do have a lot of complexity within the plan. And that's where this is where you come in. So let me introduce John Quinn, who is the founder and CEO of Wellnecity, which is a technology company dedicated to simplifying the complexity of unbundled self-funded health plans. So John, great to have you here in the Healthcare Lounge. Are you in North Carolina today? You've got you muted.
We're having technical difficulties today.
That is okay. Good to have you. Good to have you here in the lounge. Are you in North Carolina today?
I am in North Carolina enjoying some spring sunshine.
Good. Same here in Nashville. It's a beautiful day here in Nashville. All right, John. So we're talking about all right. So a self-funded plan is not inherently complex in terms of its main working components. TPA, PBM, medical management, stop loss, some sort of repricing mechanism for claims, network in the case of a carrier, reference-based pricing, direct contracting in the case of a next-gen plan, and then all of the management, marketing, et cetera. It's not that complex. It's really just five main components. But getting those components to work together is a complex problem. Talk about that and what you see in plans where you are on the outside looking in to see what they're doing before they get involved with Wellnecity.
Yeah, I agree with you. I think you have the basic components right, Nelson. The challenge that employers face, and really all of us as people with health conditions, is how do you find the right component at the right time, as a person? And on the employer side, how do you make sure that the components that you've bought for your people are working for them at the appropriate time? And that's what we set out to help, is really to create transparency around who's working on what problems and transparency around how they're doing, right? Is it really working? Is it successful? Is the money you're putting to work actually being put to good use? You're on mute.
This is an issue in terms of the advisor's role, picking those components. That is, I won't say it's complicated, but it can be a complex question. Which TPA? Well, that depends, not just on the TPA's performance, but also on other components. You might be wanting to bring in a medical utilization management firm that doesn't work with every TPA because they have requirements. Some PBMs have functionality that you may not want them to have, et cetera. So the question is measuring the performance of the vendor, of the solution provider, but there's also a connectivity issue. Talk about that.
Yeah. So first on, I had a thought while you were talking. First on the vendor, we spend a lot of energy on filtering through vendors and buying a vendor and contracting with that vendor and then rolling them out. We can't lose sight of the fact that what we're really trying to do is buy a solution, right, for our people, right? We're buying health benefits, something to help with a health condition, not vendors. So the connectivity problem, it's really an information problem. And if you think about a person, if there was one vendor or one component that served their needs, we'd have, health plans that had a single component. In fact, people have different needs across time. So it's important to connect the vendors to be able to actually support that health condition as it moves across time. So, I'll bring it into some pragmatic examples. Primary care. I first have a primary care need. And, for families, that presents one set of, pediatric or childhood, care issues. For a 50-year-old like me, who's receiving health care for the first time in my life, it's a whole different problem, right? Or for a 60-year-old with a lot of different conditions, it presents an even different problem. So helping that person connect to the right solutions, to the right subsets of the vendor's capabilities is really important. And what we find over and over again is the vendors are capable, but they're dormant, right? They're sitting there silent because they're waiting for a person to reach out to them. And if the person never reaches out, there's no value. So we sit there and try to reverse, the tide and basically connect all the vendors, help them understand the health condition of the people in our health plan, and we push them out towards a people. We help them reach out towards a person when they have a moment of need. And as you can imagine, we focus on some of the high value things like somebody just got diagnosed with cancer, or somebody's headed towards a spine surgery, or somebody just received a recommendation to prescribe, or to take Humira. So there's a lot of lower level problems, and if the vendors aren't connected, it's hard for them to actually deliver their capabilities.
So facilitating the communication of the value that a solution provider vendor brings out to the patient, to the employee who needs to be a patient, has health issues, really gets to the entire point, which to your point, that this is a health care plan. So the purpose isn't to provide insurance. The purpose is to ensure that as Deb Alt puts it, the right patient gets the right care from the right provider at the right time at the right price, the 5 R's. So communicating out the message to employees or connecting employees with the care that's available is one aspect. There's also the interconnectivity of these different vendors, these different solution providers, who all have different spreadsheet formats. They have different data requirements and data needs. How does an advisor, other than building an ad hoc pipeline between, API between vendors, that if the vendors change, then the whole pipeline has to be rebuilt, et cetera. How can they deal with that better?
Yeah, so I'm going to give you a precursor. So you talked about communication. That was the point, right? How do I communicate to a vendor or a person when they have a healthcare moment? A precursor to communication is to have better information. And we can simply put data, in as another word for information. What we learned early on as we were working with health plans that were unbundling is that many of the vendors weren't getting the information or data that they needed to do their job. So the upstream system, the PBM and the TPAs, were holding data captive, holding, data to themselves. And as a result, the data or information wasn't getting to the specialized vendors. So what we did is, because we're a technology company, we said, hey, Mr. or Mrs. Plan Sponsor, you've hired these vendors to serve your employees with healthcare, right? To simplify it. But they're not getting the information they need. I can gather that information for you because it's my job, and I can push that information out to each and every vendor. And to give you a visual, Nelson, the world today tries to distribute data in a many-to-many form. So if anybody's ever watched an implementation, if there's 10 vendors, right, downstream from a TPA, there's 10 connections that are set up. Well, using something like the airline industry where we use hub and spoke, right? We don't fly to every city, we fly to hub cities, right? And people get themselves to the hub city, and then they can get themselves to the next leg of the journey. We use the same thing with information. We act as that hub, right? Bringing the data in and then pushing it to all of the smaller data users. We could talk about all the technology, APIs and all of that, and messages and FHIR. It's really not needed, right? Technically, it's not a technical problem. It's really an organization problem and making sure the information gets pushed out. What happens is we actually push all that data to those vendors. We now have a digital connection with them, and they can start passing information back to us. And that's where the magic really takes off, because as they pass this information back, we can actually see how they're doing. We can see who they're working on, and we can help them do better.
So it's not just a matter of communication, it's a matter of efficiency.
Absolutely. And completeness of communication and efficiency in capturing data.
So advisors think in terms, or at least the smart ones, especially if they're putting compensation at risk to guarantee results, which a lot of our next gen advisors do. They're concerned that the point solutions, those vendors downstream from the TPA and PBM, are doing their job to control costs, because the part of the advisor's compensation is dependent on those costs being controlled to a certain amount, to a certain number. But there's also the concern, and you keep coming back to this, and I really appreciate it. This health plan isn't for the employer. It's certainly not for the advisor. It's not for the vendors. It's for the employees. It's an employer-sponsored employee healthcare plan. And the fact that you're able to not just direct care to the right employees, but then be able to monitor that care, to measure the results, and to ensure that activity is happening that's being promised, because without the activity, there won't be any results, is really encouraging to me, because I think for a lot of advisors, it's you put the point solution in the plan, and then you cross your fingers and pray, and you wait to see the final results at the end of the year. Did we hit our savings number for the employer? Whether there's a bonus attached, whether there's compensation at risk that you might have to write a check back to, it doesn't really matter. If it's just, do you keep the account? You maybe lose the account because you didn't save the money you promised. You're really blind in a typical unbundled health plan. You're really blind as to how your vendors your point solutions are performing. And you're saying that that data is available to pull back from or pull from the point solutions during the year to monitor not just the activity, but the results.
Yeah. So, you said blind, right? Which is a terrible feeling, right? Like, anybody says blind and some part of you kind of tightens up inside. So you're not only blind, as you mentioned, but you also linked it to their livelihood, right? So you're dependent on that vendor doing what they said. And it struck us, and this is 4 or 5 years, 5, 6 years back now when we got rolling with our company. A lot of energy is spent on what's the strategy of the employer, right, with regard to HR benefits. And then how does that break down into all the benefit pieces? Okay. And then you pick up this thing called a health plan. And I'll stay with the 5 components. Right. You go out and you do an RFP and you buy what you hope to be the best vendor or component, right, to fit the category. And then you negotiate terms and then you implement and then you enroll, right? And then January 1st arrives, the first day of the plan year, and everybody's out of gas. And what happens next? Right? I mean, when this vendor really goes live and healthcare is at issue and your members are looking to receive the benefit of all the hard work that you've gone through, what happens? Right? I mean, it's a very unsettling feeling. You hear employers say, well, let's see how January goes. You see advisors say, well, let's wait for first quarter reporting. The system, the buying system, the employer, right, basically goes passive at the point that it should go active. Right? I don't stop, right, with my car purchase after I've picked it on a page and said, I want this one, right? It's an active process to go through and make sure it's working and to keep it working. Right. So what we bring to the equation is a operations, right, that actually takes away that blindness and reduces that it doesn't reduce the dependency, but it changes the odds of success. And the brokers aren't, right? They're basically counselors. They're not health plan operators. So we think it's odd that you would go, buy a solution and then subject yourself to wait and see without bringing a partner onto the table that's actually making sure that all the pieces are working for the next 365 days.
Can you give us a before and after look? Let's say advisor has a health plan that's running with an employer, but it's being done the traditional way, which is, we hope for good results. We think we've done a good job putting the pieces together. Now we're gonna just pray for good results. The before and then the after, once they've implemented a technology solution that gives them not just the interconnectivity, but the data flow back from those point solutions throughout the year, not just at month 12.
Yeah, I was I'll give you a situation I was actually talking about with a very, very large advisor yesterday. We had a top 3 PBM that was in an RFP process and basically won the bid, for the PBM. Okay. We, because we're data oriented, we basically said, if this thing performs, this is what our forecast looks like week by week. So we used the prior year's data and we basically applied the new contract and we forecasted, a blended number. Okay. On January 1st, everybody goes live. Well, most people know that you normally review your PBM in May and June on how it's done year to date. The interesting thing about that situation is you review it in May and June, but at that point, it's almost too late to replace it for the next year. So you're stuck with whatever you review in May, June for typically 2 years. Okay. In contrast, the first week of data came out and the numbers were off like 20%. The second week, the numbers came out and they were off even more. And by the end of the month, we were off by 30-some% between what the contract said it should yield, which we had modeled, and its actual yield, on pricing, consumption, all the, we actually break it down. We went back to the big three PBM in February and said, Houston, we got a problem. And they said, we think it's your problem. We think you messed up the enrollment and therefore our original proposal and the numbers we put, won't work. And we said, no, we've looked at this and these are your numbers. These are the parts of the plan you're responsible for. So we negotiated back and forth, the month of February, and they agreed with us that over half of the issues were their problem. By March, they went to work on curing. By April, they were back on forecast. Right? By May, the clouds had, parted, the sun was out, and people were happy about the PBM. The advisor, in this situation, wasn't necessarily working with us, said, hey, what happened? And, we said, well, there was a problem. We saw it. We, worked with the PBM and, we fixed it. So, there's a lot of benefit to early information, early transparency on results if you're going to fix it. So we're always, people call us a spotlight. Right? We're spotting the problem and then we're going to work with the vendor to fix it. And the advisors we work with basically calls their blindside tackle because there's a lot that goes on with a benefit program beyond health. They've got a lot of things to worry about. They're already into the next year with regard to planning. So they're leaving us, quote unquote, behind to watch to make sure last year's efforts are working.
So I think that's fascinating. What I love is you're basically getting real-time data. To your point, looking at data 6 months later is a lot like looking at the ashes of a campfire. I mean, the fire's out, nothing you can do about it. And at that point, you've lost 6 months of cost savings, or you've overspent for 6 months. In the case of this PBM, if it had continued to stay and get worse off projections, but the real-time data, and not only do you have real-time data, but you've got data that you then can show the vendor. So it's not guesswork and you don't have to take their excuses. I think what jumped out to me the most in this, John, is your ability to fend off and debunk the PBM's attempt at deflection to the advisor and the employer who you didn't enroll it properly. And, if you don't have hard data in your hands, you're just maybe got limited data or you're sort of guessing.
Nelson, you're defenseless. I have sat across the table on things like claim accuracy and, the medical network and the TPA and their claims accuracy people have all the information. And I sit there with this bare bones claim trying to make a case that, hey, there's 400 of these things. I think we've got an issue. And they slice me 6 ways to Monday. Right. Now, if that claim is a year old, right, which is the traditional audit, my chances of doing anything go way down. But if that claim, which is what we like to do, speed the system up, comes in on Thursday and is going to get paid next Wednesday, and I mark it and say, I'm not paying this until you answer some questions, it changes the competitive dynamic completely. Right? It puts the burden of proof back on your vendor rather than on you.
Well, there is nothing more powerless than having already spent the money. And there's nothing more powerful than holding the checkbook and refusing to pay the money until you're satisfied that you've got the right results. So being able to get on the front end of that is powerful. Let me talk to you about, or let me get you to talk about reports, because the value of this data, if it's raw data, it's not very usable to most advisors because, frankly, they are not. Most of them are not sufficiently detailed in terms of all of the aspects of a plan because there are so many things going on. So what they need, and there's so much data, it's where do you focus? So having a report that distills this raw data, this massive amount of raw data down into something that's usable, both for the advisor, but more important for the advisor's client, so that the client can understand and doesn't necessarily have to be explained. John, I had a CFO speak at a conference. I was running the benefit advisor leadership track at the World Healthcare Congress several years ago. And one of the panels was on talking to the C-suite, had a CFO on. And I said to him, what advice do you have for these brokers and advisors in the audience who want to come and talk to you and your peers? And he said, 2 pieces of advice. First, lead with data. Second, finish in 15 minutes.
Yeah.
And then we can continue if I want to, but finish in 15 minutes. The point, though, was the data. We can't make decisions without data. We can't be confident in our choices without data, but the data has to be usable. We have a CEO who has a next-gen health plan. He said before he went with this particular advisor, Mike Hill out of Michigan, before he went with Mike, he said, we used to get a lot of data from the insurance company, but they never gave us the secret decoder ring. That's where the reports come in, where they correctly and accurately distill all of this data down to something usable. Talk about that.
Yeah. So one, I'll give you a word first, right? That CFO he's asking for facts, right? So data is a precursor to facts, right? Facts is something that we derive, and most decision makers can't live with speculation. I think this may be, we don't have time. They don't have time. They need facts. And then the second thing, the time, right? Back to we don't have time. I'll give you a phrase. Well, it's not a phrase. So top 3 PBM report. If anybody's ever seen the quarterly reports coming out of big PBMs, the label that's been put on them is a wall of numbers. That's one report. If you're a pharmacy person, if you get a wall of numbers from every single PBM that you work with, and you've got an employer base that has a dozen PBMs, God help you, getting the expertise to interpret that, there is no decoder ring, right? It's just this mass haystack of information. So what decision makers really want is, I really could care less about the 26 pages of crap that, is moving in the river of pharmacy. I need to see the two nuggets that matter that I should do something about. Because I'm here to do something. I'm not here to read paper. Right. So back to your reporting. I'm gonna close on this, Nelson. A report library. We always say that, a report library is, like a haystack, and, finding the needle, is a real challenge. And, reports are loaded with insight. Right. But the question is which insights do you pick up on? Who's going to actually pick up on those insights? And we kind of tongue in cheek say, insights without action is just a report, right? None of us wants to read another report. What we want to do is go figure out what we're going to do tomorrow. And I think you had somebody, that you mentioned to me a few weeks back, where they handed her a big report and they said, so what do you glean out of this? And she kind of turned it around and said, well, what are you going to do with it? Right? Where do I go take action? Right? And that's what the 15 minutes is standing for, is somebody to actually think through what are the 2 or 3 things to go do next. That's what everybody's craving.
Well, and I think we forget.
In my humble opinion.
No, it's not humble, but it is your opinion. Well, I think a lot of us forget how organizations operate, large organizations operate when it comes to data. In the legal field, when you get a order of discovery, the court grants you discovery of your opponent's case. And so you're requesting all this information for them. We'd like your emails, we'd like your financial records, et cetera. A very, very common tactic in large, sophisticated, complex cases is a truck will pull up outside of the attorney's office, a big truck, and people will start unloading banker's box after banker's box after banker's box full of documents. And there will be 40, 50, 60 of these boxes full of file folders. And the point is, there's something in there, but it's a needle in a haystack, and good luck finding it. The good investigators love that because they know there's something in there. We just have to go through and find it. But that's daunting. And no advisor has time to go, or the expertise to go through all of the data that a PBM dumps on you, right, that a TPA dumps on you. And so having it distilled down into reports. But how do they know what reports to get, and how do you know what reports to create?
Yeah, so we try our best not to be in the report creation business. That is a slippery slope, because every time you create a report, you're creating a view on quote unquote last year's issue. And if you add that to the library, it just accumulates and becomes one of those 40 or 50 boxes, right? So for us, it's really about pointing to information that needs action on. And if you think about those 40 or 50 boxes, to maintain overwatch on things getting slid into all of those boxes each and every day to find the thing that matters is, it's almost impossible from a human standpoint. It's absolutely impossible from a cost standpoint. What we do instead is we turn that over to the machines, right? So the machine can sit there and say, when this one situation occurs, I want you to tell me about it. And your sole job, right, as a little piece of code, is to watch for that thing and to alert me. And if it doesn't happen, I don't want to know, right? You're silent. Well, we do that in thousands of places, right? So we turn it over to the machine instead of a report. And we're getting, 5 alerts instead of 20 reports to go find those 5 alerts. That's a big, big difference that, the world is moving towards.
So you're developing a set of data points that you're monitoring for. And only when those data points hit is there an alert. So basically you've automated the process that in the past would require an advisor or one of their staff to sit there and comb through all of this data looking for, we've got advisors who do that with claims. They will go through the large claims, but even they don't know every CPT code. And so they are likely to miss. It's not their full-time job, but they do know that they're looking for a gynecological CPT code on a male patient, for instance, or double billing, some things that jump out. But what you're telling us is because of machine learning and machine reading, that you can set up these red flags to be tripped when the data hits.
Yeah, and this very basic. So I'll give you an example. Enrollment. That is a very simple term, right? A person that's enrolled for health benefits, but a version of that enrollment sits in the benefit system. It sits in the TPA, it sits in the PBM, it sits in every vendor, sits with your stop loss. We had a situation a few weeks back where actually making sure that enrollment is consistent across every one of those systems, a lot of people do that manually. And there's human errors that can put it off. Like, hey, this person got released and somehow it didn't get into it got into system A and didn't make it to system B, and system B feeds everything else, right? So we automated the checking of all of that to actually occur on a daily basis tied to the rules of the health plan. We found 300, it was 300 to 500,000. And it's funny that it's not funny. Basically, somebody was let go, the plan paid for it, right? And the stop loss did not. And it was because the stop loss didn't recognize basically the enrollments were out of sync. So that error led to a, $500,000 clawback, because of inconsistency. I may have some of the facts, like which enrollment was off, but that right there is something that if you talk to any back office health plan account manager, they're making sure those enrollments are in sync. And a lot of times it doesn't get done because every day or every month, because just the human effort, it's too much, falls off the slide of the desk.
Well, human error is all too common in adjudication and other critical areas. By the way, so in our last 15 minutes, if you have questions, just pop those into the Q&A box at the bottom of your screen. Click on Q&A and put the questions in. Don't wait until we ask for questions because you're liable to forget. Go ahead and write them down and put them in the box. We do have a question from Terry Shook, who is a terrific next-gen advisor out of Illinois. Is there a minimum group size for which you can produce a favorable ROI with the Wellnecity solution?
Yeah, thanks, Terry. I'm a Chicagoan. So hello from back in the days gone by. We used to say, that 1,000 employees was kind of the smallest we could go to find enough activity to justify our presence. That has changed. So starting about 2 years back, we started serving brokers and serving their entire portfolio. We call it our broker back office solution. And in that situation, we can serve basically every self-funded plan in your portfolio. So, if we have an advisor that takes on the account relationship management role and takes that away from us, which we love to get rid of that part, right? It's one of the hard things out there. And we just let our platform operate. We can serve employers of all sizes.
What are you seeing in terms of the most impactful results that advisors are getting with both the connectivity, the communication out, the engagement of the employee to utilize the healthcare, measurement of the healthcare that's being delivered, the vendors' activity and results, but also the reporting and the monitoring of the overall plan? Where do you see the most impact?
Yeah, I'm going to talk about within the context of connectivity, your whole idea of connectivity, Nelson, and the idea of if there's 5 major solutions, there's probably a second set that's equal in number that have a lot of value. And the biggest impact that we're bringing for the advisors we serve is being able to turn on a whole basket of solutions all at once rather than turning them on one at a time.
Give some examples.
Yeah, so we have a vendor that we're getting to know, Nimble. It's based out in the Northeast, and it's basically, they manage the MSK episode of care. Okay. That may be number 10 on somebody's list to run an RFP and go after the value of managing musculoskeletal cost. But in a situation where they're pre-connected, they have a case rate, which means they charge for each person. And you don't have to implement them you don't have to implement them for each employer. It's kind of a benefit of being part of the connected portfolio. And that list goes on and on. There's Diatribe that runs insulin. That may be a solution that was on the edge, but it's very easy to turn on once they're connected. Second opinions are easy to turn on once they're connected. What we're seeing is more and more high-performing networks, whether it's imaging or orthopedic, or mental health, or reproduction. We can turn those point solutions on much more easily if they're already connected.
Where are advisors making the most impact with their employer clients, with the data that they have available through a platform like yours?
Yeah, the advisors are the spokesman, right? So they're really fielding the questions that the employer is generating. They're building confidence. They're educating the employer about what's working. And then they're basically bringing back the performance data to show the employer that it is working, building confidence to go out and do more. So, chief educator is what I would call, chief educator and chief problem solver, is to me the role of the advisor in helping that employer navigate, healthcare.
We have a question from Frank Conklin. He writes, sounds like you're making all the parts of the benefit system talk to one another through using data in real time. We believe what's important is that there are interrelationships among the vendors in the continuum of care. do you create those interrelationships?
Yes. So if you think about that hub and spoke, it's not a data only kind of ecosystem. We think of it more as an information router. So a lot of us have network hubs at home, and an information router says, I have a new piece of information. Where do I send it? So I'll give you an example. We have a client that has an app for the member. They have their service center with their TPA. They have a care management function, and they have some specialized disease managers. Well, each one of those actors is in touch with the member, and we know who's in touch with whom, right? So if we need to get a message out to a member, hey, I saw a cancer diagnosis and I know you're with the diabetic disease management, I can actually send a piece of information to that disease manager that I want to talk to Jane because she just got a cancer diagnosis and I want to make sure she gets a second opinion at Mayo. So the routing is actually intelligent, right? We know all the touch points with the member, and we can use that touch point to either listen for new information or to broadcast to a member that, they have a moment of need and we need to get them over to vendor B so that they can be helped.
All right, in the last couple of minutes here, John, what advice do you give to an advisor, not to come run to Wellnecity, but in terms of considering the complexity of an unbundled health plan? What basic foundational advice do you have based on what you've seen in the marketplace?
Unbundling is a journey. It's my assertion that it's here to stay. There's some that would say it's too complex and we're going to go back to the world of the BUCAs and the fully bundled. What I would say is pay attention to the data that you're getting and make sure you're negotiating the right rights. So what do I mean by that? Instead of 30 days cycle time on data, go for weekly or daily. Instead of 20 pieces of information sent to 2 vendors, ensure that there's some mechanism to get all the information sent to all your vendors. You have a lot of power at contract renewal. I think in addition to better information, you can also negotiate more specific performance. So more and more, we're seeing vendors sign up for performance, but we're not letting them report their own performance. We're actually engineering in the data what we need to see to be able to believe performance is happening. So faster information, more information, and push for performance guarantees. The market is actually accepting those. And we think that's the next, kind of field of battle to push more and more performance back on the vendors. They're capable, they just need to be pushed.
Where do you see, you spoke to it in terms of you think unbundled self-funding is here to stay. How do you see it developing? Is it mostly going to be upmarket in terms of group size? How far down market do you think it's going to go, given that we've got some really good small group self-funded plans that use level funding? I call them rebundled self-funded plans that are very next gen in their cost containment and overall design. But how far down do you see unbundled going before it becomes too cost ineffective for an advisor?
Yeah. So if the advisor can rely on partners to bring infrastructure, right, that connectivity, there's no reason for them not to embrace a full suite, because what will happen is you'll turn the management complexity over to the pool. It's a bit like turning your stop loss over to a captive and having the captive have an ecosystem of vendors to manage those high cost claim sets. You can take that same concept and bring it down into the rest of the plan and say, for healthcare spend below my limits, my stop loss limits, I can similarly manage my risk, right, my spend, with a bundle of actors designed to, manage them effectively and motivated to manage them effectively. So, we're a young company, we're a small company, we're going to make the step to self-funded next year, and we're 50. And part of the reason is I want access, right? I want access to COE. If we have a baby that arrives and they need to get up to Boston's General, right? I can't do it with the regular system, or Boston Children's. I can't do it with the regular system. But I know, right, that if I have an unbundled plan, I have the doorway into those healthcare systems to get the care that I would like for our people. I had a CEO quote early on. He goes to me, John, he was in healthcare himself, and he was our first customer. And he said, John, my only wish is that we could serve our people with regard to their healthcare with the same love and care that they serve our customers. They're in the hospice business. So they have people who go out every day and help others. And he rewards that, right? He encourages that. It's part of their culture. And then he said, and then I give them this crap thing called healthcare benefits, and it makes me feel bad. So, go fix it for me, because I want them to get better healthcare.
Well said. I think that's, we had a conversation, our mastermind monthly celebration event was yesterday. And we had a conversation about delivering the healthcare plan is designed to deliver healthcare, not drugs, not surgeries, but healthcare. So how best to deliver that care? It might involve surgery, it might involve a drug, but do you just hand them the drug, or do you perhaps put them through a protocol? The GLP-1s, the weight loss drugs, were under discussion, and it's, do you create a protocol that is around behavior modification and psychological readiness to participate in a drug regimen like a GLP-1? And is that fair? Well, of course it is, because you're actually speaking to the health of the employee, not just paying for a drug, right? So insurance pays for a drug, but a health plan should provide health care. And I love his mentality of, I'd like to take care of my client, my patients, or my employees the way they take care of our clients. John, thank you for showing up. Glad you made it a few minutes late, but delighted to have you. It's an important message. The complexity of unbundled plans can be managed. And the better you manage, the better the outcomes, both for the advisor, the employer, but also the employees. So thanks for showing up in the Healthcare Lounge. We'll be back next month with our friends at Coral. And the topic there is a network that's not a network that replaces a lot of non-network solutions to the advantage of the patient, the employer, and the advisor. So we'll look forward to seeing you next month in the Healthcare Lounge. See you then.
Thanks, Nelson.
Thanks, John.